Welcome to InnerSight, Health Optimization with Rudy and Shaun.
Podcast number 13, Shaun. We've got an amazing guest today, and it's quite an interesting story how we got to the topic of iron. So in our InnerSight screening, we deal with inflammation and how to become a better person metabolically, and somehow we've discovered that iron is a bigger issue than we really thought. And yeah, it's been a journey with the ups and the downs of iron.
Absolutely, and I mean it's the women that's low and the men that's high often in the testing. And we had to go back to the books and look at it and speak to the experts in the field to get our knowledge about iron up to date.
Yeah, and I think with our guest today, I almost want to say, if you listen to any of our podcasts, this is the one you can use for your whole family. Make sure you know about it, and that's why we had to bring in the big brain. So, and with that, I'm going to introduce our guest today, Professor Vernon Louw. He is the Professor of Hematology at Grootskeur Hospital. He actually brought me into the iron world that I understand it better. So welcome.
Thank you very much, Rudy, Shaun. Lovely to be with you.
Great. And we are going to take iron from its basics. So iron is a micro element that we have to live. It is pretty much the building block of how we carry oxygen, and also a big coenzyme in how a lot of our processes, at least 17 of our processes, work. So maybe with that, I'm gonna leave it with you. Let you just tell us a little bit about what iron is and how it gets into the body, how it actually works.
Right. No, thank you very much. I think many people know about iron, but I think many, if not most, have a misunderstanding. And I think even many medical doctors have a misunderstanding about the importance of iron. So what most people would know is that iron is a critical element for red blood cell production. And red blood cells are the cells that carry oxygen. So you need iron to make hemoglobin, which is something our listeners might have heard about. And without it, you will become what we call anemic. So your hemoglobin will drop and you will have a whole range of symptoms. I think what many people don't know about iron is, number one, that iron is used in every single cell in the body, and that only 50% of the iron goes to the bone marrow to make red blood cells. So where does the other 50% go? To every other cell in the body. And the amazing thing about it is that it's critically important for many, many processes, as you said, including the energy production process in the cells. And I've often thought about this, and I actually spoke to someone recently saying that I think there's a part of our biology that I think we have neglected, and that's the mitochondrion. I think the mitochondrion and its health provides a kind of a unifying theory for many of the health problems people struggle with. And iron is key to that. And in the mitochondria, apart from this production of hemoglobin, or part of the hemoglobin molecule, is the production of a molecule called ATP, which is our key energy molecule.
Yeah, so if we bring it back, so for our colleagues, they should know what ADP to ATP, we need that phosphate to move, and that iron is obviously one of the key elements to do that for our non-medical people. So that ATP is actually your energy pocket of the body. So that is what you need. And I think for a lot of our medical and non-medical people, that's news. So
yes.
Yeah.
And because of that, and this is, I so often hear patients say to me, I went to my doctor and when I asked them about iron, and they would tell me, no, the doctor said my iron is fine. I said, okay, can you show me your tests? And then what they show me is a hemoglobin, and there's no iron tests to be seen.
And it's just one piece of the story.
Hemoglobin is only one piece of the story. Exactly. As a matter of fact, a hemoglobin that is low is what we would call now the end stage of iron deficiency. Long before your hemoglobin drops, many other cells will be starved of iron, because the body obviously don't want you to die of too little oxygen. So iron will go to the red blood cells first, starve the other cells in your brain, and people will recognize people that are iron deficient. They are irritable, they might be anxious, they can be depressed, they
brain
have
fog,
brain fog, they struggle with memory, they feel fatigue and tired, and so many symptoms that you can have without being anemic. So it's not good enough ever to do a hemoglobin to determine whether someone is iron deficient or not. You will, as a matter of fact, we've got studies that show you'll probably miss more than 40% of cases of people with iron deficiency if you just do a hemoglobin.
Oh, that's massive.
And I want to thank you for that it's actually been driven so hard in South Africa at the moment, because, I mean, a lot of research since 2017 till now, the last 7 years, iron has exploded. So
Sure.
If you're listening to this and you haven't updated yourself on iron since 2017, the new stuff is out there. Ferritin level has changed. So maybe while we talk about ferritin, so if someone is listening and they're thinking of switching off now and we're boring you, just remember ferritin. If you remember ferritin, your GP will actually do some tests that's going the right way. So maybe just bring us in. We talked that we're going to talk about the ingestion, but maybe let's talk about the test.
Okay. So number one, when people think about testing your iron, it's not just saying to the lab, test my iron, because that can actually give you a false impression. For instance, if you literally go and test your serum iron, but you do it non-fasting, it might look completely normal, as an example. And it's not a good test, because there are other things apart from iron deficiency that can cause a low level of serum iron. So you can't really make sense of that. So you need something else. And there's a little storage molecule, I call it the pantry for iron in the body. It's called ferritin. If you remember the word tin at the end, it's like a little tin that you store the iron in. And this storage molecule actually gives you a much better idea if you're short on iron or not. And this cut-off value or reference range for when you're supposed to be iron deficient is increasing the more we know about iron and its symptoms. So in the old days, and we unfortunately still see it on some lab results, reference ranges, they would say a ferritin less than 15 is low. Yes, it's low, but there are levels that much higher than that that's also low. So you can't ignore levels that are higher than 15, but lower than certain others. So at the moment, we use a ferritin of 30 as a standard cutoff, but I need to put in a disclaimer here. We've just completed some research that I can't talk about yet, where we actually did bone marrows on people to see what should that cutoff be. And what I can tell you, it's more than double that.
Wow.
But that's for another day. I don't want to go into too much detail before the publication is out. But the point is, a ferritin less than 30 is definitely low. There's nothing else that's going to give you a ferritin that low. So if your ferritin is below 30, you need to treat it. But we also have to note that there will be people with ferritins above 30 where additional tests may be required that can help you make the diagnosis.
And that's example when there's inflammation, because
Correct.
ferritin is a...
Exactly. So if you, so that's a good point. You know, it's not the best time to test for iron deficiency when you go to the doctor with a pneumonia or with a cold, because at that moment, especially not with COVID will shoot your ferritin into the roof, and you will not be able to make head or tail of it. So the best time to go is for your normal screening, to check your checkup, your annual checkup with your doctor. Ask them to do your iron when you're feeling good. or well, you may not feel good if your iron is low, but let's say when you don't have an infection, at least. If you've got an infection or something like that, your iron studies become unreliable.
Okay, so let's move back. I wanted to get that, so people sometimes listen to a podcast for snippets. So
okay.
we talked about the testing. So let's bring it back. So if you might be low, so which people do we think might be low?
Right.
Because they probably ingest low, or they use a lot, or how do we think about that?
If you gave me one word to answer that question, I would say women. But we've got a few more words today. But women is my one word. And I like the title of an article, and I met the author recently at a conference. The title of a recent article that was called "The Misogyny of Iron Deficiency." And what it basically says is that we have really neglected women, and we've not taken them seriously when it comes to iron. And women, especially women in their fertile years that are menstruating, let me give you numbers. A study done here in the Western Cape has shown that more than 50% of apparently healthy women have iron deficiency. That's more than 1 in 2. Now that should have every health regulator, governor sit up and run around and
Medical
do something
aid,
about
everyone should want to do something about
it. But, people are not filling up the ERs. Women are tough. They take it. They live with it. They think, they're often so used to this. And many doctors have given them a cold shoulder, and they've become accustomed to it, sadly. And I say this not to to badmouth doctors, because there are amazing doctors that really attend to iron deficiency, like you guys with your clinic. But I see those patients who come to me for a second, third opinion for their iron, and then I see it's obviously low, and doctors have refused to treat them because they say, no, this is normal, or they don't know what these new values are that you've talked about.
Yeah. So I hang my head in shame. For more than 20 of my practicing years, I was one of them. I had no idea.
But a question, we only see what we look for.
True.
Is it always been like that? Or is there something like a cause for why we see such a high incidence of iron deficiency? Or is it just because we're looking better?
I think the awareness is increasing. I definitely think the awareness is increasing. A lot of education is happening globally. The people are taking note. The World Health Organization has taken note. So they've already brought out a number of publications, and there's now a very big publication. And I've been part of this working group to put together a global implementation plan for how we will address, amongst others, iron deficiency on a larger scale. And I think conferences of many different specialties are now taking note, because iron deficiency affects you when you are in heart failure. It affects you when you're pregnant. It affects your baby when you as the mother is iron deficient during pregnancy. It affects you when you are overweight. There are so many situations in which iron deficiency has a very negative, additive effect on what you already struggle with, that people are now bringing it in. And I think all of us are being educated better. I was certainly, as a medical student, I only knew about iron deficiency causing anemia. And I thought that all the symptoms that they listed, maybe apart from the cravings, was due to the anemia. I was so wrong, and I also had to learn all of this later.
Yeah, we just before the podcast, we had a little chat about just recovery and repair, and how vitamin C plays an important role in repair, and where iron is needed to do that conversion. So, as you say, it's not just the anemia. There's so much more involved.
Absolutely.
In this.
And that's for our colleagues like the orthopedic surgeons and the surgeons. If they have to have skin repaired, and they can actually have someone with with a normal iron, that will help so much for the repair. I mean, if someone is that low that their hair starts falling out, then I mean that hair is not getting iron. So
totally correct. And that's a very common symptom, actually. About half of people with iron deficiency have hair loss, or nails that break easily, and so on. It's very common.
No, we actually had a referral from a dermatologist yesterday regarding exactly that.
Sure.
And I think I might bring in a personal story here, how I actually got to iron and iron deficiency is actually my wife. We both thought she was fine, and she started mountain biking, and she said, but she can't keep up with the other people. And we started scratching. We looked for B vitamins, and she went for B vitamin injections in the bum every week or whatever at the pharmacy. And then we started scratching, and then we realized, but she's got a ferritin of 8. And
that's very low.
And then, but she had a normal HB or hemoglobin of around 11.3. So it's close to what I would have always thought is normal-ish. And suddenly we gave her an infusion, and now she's riding a mountain bike like I can't. So it's amazing the difference you can make with getting iron to a normal level.
Absolutely.
I just want to maybe ask Vernon, how much do you need? How much iron in milligrams or grams, or how does that picture look?
Right. So normally we absorb iron, or a very limited amount of iron, from our diet. The body also needs to protect itself from an overload of iron, which we'll probably talk about later if there's time. But it's typically 1 to 2 milligrams of iron per day that comes from your diet. And normally your diet contains 10 to 20 milligrams of iron per day. And you absorb about 10% of that. Now, there's a big difference between different types of things that you ingest. For instance, your better sources of iron would be heme iron, which comes from red meat, so beef, pork, poultry, all of that, especially organ meats like liver, very, very good source of iron. But iron from vegetables, and we all have heard about Popeye and spinach, is actually very poorly absorbed. So if you go and Google spinach and iron content, you'll see, it looks very good. But you need to eat calculated between 2.5 and 4.5 kilograms of spinach every single day just to meet your daily needs.
That's like a...
Yeah, it's a big bucket. I've not met many people that can do that. And then the other thing is also when we take iron supplements, you look at the box and you say, how much iron is in here? Just listen to this podcast. They say I need about 1 to 2 milligrams a day. And then you say, 300 milligrams per tablet. What's going on? But that 300 milligram is actually not the iron. That's everything in the tablet. There's lots of other stuff to keep that tablet together. And then you need to look at the elemental iron, which is, let's say for iron sulfate, ferrous sulfate, which is commonly used, 60 milligrams. That's still not the answer. How much of the 60 milligrams will be absorbed on a daily basis? 2.4.
Wow.
So people often, I've heard people say, well, if you take one of these tablets, I should be fine for a month. It's not how it works. And every type of iron tablet is different. And one needs to look at the package insert, see what the elemental iron is. You need to know what. And this is where you actually need your doctor's advice to help you get the right dose and the right amount and know how to take it. That's also changed quite a lot.
Yeah, I think that's probably where we can maybe it's a long discussion, but
sure.
I think we'll point our colleagues to your YouTube channel to maybe just see, because it takes months to actually, even if you do an intravenous infusion, more than a month to really get the value out of iron.
Yes.
So it's quite an educational process. So I think our colleagues that are listening to this should actually dig deeper if they think their patients are, or I can tell them they will have patients that are iron deficient,
sure.
how to actually treat them. So
yes.
That's it is quite a difficult thing, and you need to understand which iron you can take every day.
Exactly.
One. So I think
right.
that's quite important.
But maybe a few fun facts about the diet, if you want to. Or let's say how your diet can affect your iron absorption, especially if you're on iron supplements. Many people are. So I think it's important to know that there are many things in your diet that can block iron absorption. So you don't...
It's like the tea and toast diet of the old people.
Yeah, exactly. So take the tea and toast. So the tea contains tannins, coffee contains polyphenols. Your cereals and your bread contain phytates. Eggs contain phosphatin. Calcium will compete with iron for absorption. So milk will also be a problem. So you've got all these things competing with iron or blocking iron or binding the iron, and it just goes right through. And there it's very important to look at the specific iron supplement you're taking, because some of them you have to take on an empty stomach, whereas others have been designed to take with all these foods without a problem. If you take a bit of orange juice, for instance, that will help your absorption of some ions. It will not make a big difference for others. So I always say you don't have to stop drinking tea and coffee. Just keep it for tea time. Keep it away from your iron, a few hours away. Don't drink it at the same time, because you're going to have problems. Except for rooibos tea.
Okay.
Rooibos tea, no effect. There's actually studies done at Stellenbosch University many years ago that showed, I don't know if you remember Prof Hesseling and Prof Klopper. They did it together in the 70s, and they showed that there's a big suppression by normal English tea, no effect by rooibos tea. So
that's good to know for our South Africans.
So if you think about taking iron, you really want an empty tummy if you can, and no medications.
I think ferrous sulfate is the ferrous ions generally can't be taken with food. There are some that can be, but there are a number of new ones. They're often more expensive that can be taken with food. And yes, the drugs, the medications. So antacids, especially proton pump inhibitors and the old antacids that we used to use, the H2 antagonists as well. I don't think they use that much anymore, but the PPIs, very frequently used, overused in my opinion. They can directly block both the extraction of iron from the food and the absorption.
So for our listeners that are not medical, so that means if you've got any heartburn and you're on heartburn tablets, that's normally the PPIs, and they will block iron absorption. So definitely.
So if you are iron deficient, and that's now the issue, you might be taking one of those for a peptic ulcer, for a stomach ulcer, and
which cause the
iron deficiency. So I mean, it's one of the many causes of iron deficiency. I think the important thing is to not take the iron at the same time. Either take it 2 hours before or 4 hours after.
Okay, so we've talked about symptoms. A big part of our community and the people that we test, our executives, are actually quite fit, and they would want to know, athletics-wise, if it helps with athletic performance, or the other side, if you're iron deficient, does it break down your performance?
Yes, no, absolutely it does. So Toby Richards is a colleague of mine who's from the UK that's done some studies, because he and his wife are also athletes, and his wife is also an endurance athlete. So they were very interested in this question, as have been many other people, but this is now some of the work I know. And what they did was they looked at women who are iron deficient versus others, and looked at their ability to increase their fitness level over time if they are iron deficient. And what is interesting is they do increase fitness with exercise over time, and then they hit a wall. But the fascinating thing was they did not plateau there. They actually went down despite continued exercise. So you're doing all that hard work, to get your miles or kilometers in every week, and then you get worse. And I think many people will tell you that that's exactly what they experience. They've been exercising so hard, but it's actually no longer getting better. And I think there's other things that we can talk about with regards iron and sport as well. If I don't know if you want to talk about the patients who's got maybe too much iron, or have got the.
While you've got it, let's go with it.
So there was this very interesting study done on French sports people doing Nordic skiing, rowing, and judo, and they looked at the Olympic champions world championship champions and the European champions, and they found that 80% of them carried a gene that if you have 2 copies of that gene, you would have been iron overloaded. But in this case, these people were just what we call carriers. They had 1 copy of the gene. Now, 1 copy of the gene is not harmful, but it protects you from iron deficiency because you absorb a little bit more iron than the normal person. 80% of those champions carried this gene. And that is actually fascinating because this gene is very common in people from European descent. It's sort of a gene that comes from the Celtic region. It's thought to come from originated among the Celts about 4,000 years before Christ, and it's in America and Canada, 10% of the population actually have 2 copies of the gene.
Wow!
In a study on 100,000 people, it's super common, and something we need to perhaps talk about later as well, because I think that's got its own. Too much iron is also not good.
Yeah, so obviously in sport, you've got a higher demand for iron. You need more, and you lose more.
Yes.
Through sweat and things like that. So, iron, we should actually think of iron like we think of thyroid hormone. You've got that bracket where you need to be in.
Correct.
And we should all know our levels.
Yes. So just for example, I think it's an important point. So you might be, your hemoglobin might remain the same, but your iron improves. Let's say you start with low iron and you now take a supplement or you take an infusion, your iron goes up to normal. The hemoglobin might be unchanged, but your fitness and your endurance will improve. So, and the reason for that is the ATP production that we spoke about earlier. And inside your muscle cells, like hemoglobin in the red blood cells, you've got another protein called myoglobin, which is the local oxygen store. And inside the myoglobin, you've also got iron that can store oxygen for you when you're doing exercise. So if you're low in iron, you might have normal red cells, but you might not have enough of these stores in your muscle cells, and you're going to feel it for sure.
So we actually sometimes see it also in the younger people, in the teenagers, especially the teenagers that's quite involved in sport. We had a couple of them coming to us, to our clinic, that needed iron infusion because they were so low in their iron, they couldn't perform. So they actually, the symptoms started in the swimming pool or on the hockey field, and that's where they were picked up, performance-based.
And maybe, to just take that baton from you and talking about performance. It's not just sports performance. Iron has a significant effect on the brain function of teenagers. There's been studies in the UK that showed that children or teenagers who are iron deficient test 10 points lower on the IQ test than students who are. Sure. Now, if you think about the difficulties that teenagers already have, just being teenagers, it's already a difficult time. But now you add to that iron deficiency with the anxiety, the mood disorders, cognitive problems, memory. They're already struggling with the maths. Now that just takes them to the level where they say, no, maths is not for me. I've got this belief. Once you believe you're good at maths, you're usually good at everything because it's something that switches in your brain. But once you get that thing of, I'm not good at maths, then there's often a challenge for students to really have the confidence to perform in academia because they often feel like a failure. And I think we underestimate how much nutrition, of which iron is an important part, plays a role in these things that we take for granted. We say, it's just teenage difficulties.
Yeah, it's a struggle to get them
I've seen children that's been, I've seen teenagers that's been taken out of school because of their inability to cope. And after replacing their iron, they normalized. It's amazing. Like a miracle that you see in front of your eyes.
Absolutely amazing.
I can't emphasize this enough. I want everybody to hear, and I want everybody to go and test their teenage, especially their teenage daughters, and make sure they are.
I've got an interesting story. I've actually I've got a good colleague friend that said to me, but he wants his daughter tested because his daughter said to him, she thinks she's low in iron. She read up and she thinks she's low in iron. So he had her full iron studies done. He asked me what to do. So I said, do an HB and do full iron studies. And he came to me, it's like all normal. So her ferritin was 32. It was, and it came back as normal. But she goes, everything has just been slightly low. She's had a low transferrin saturation. So ferritin was on the edge. But as you say, we should actually now start treating and try to keep people at 70 or 80 ferritin, not aim for 30.
Yeah, I aim for 100. The reason is simple for our medical colleagues listening in. Ferritin times 10 gives you your stores. Okay, that's your stores. So for a singlet pregnancy, if you have a pregnancy with a single child, if you're going to have twins, you're going to need more. But if you have one child, you're pregnant with one child, you need 1,000 milligrams of extra iron for that one pregnancy. If your ferritin is about 100, you're good. But I see people going into pregnancy, they're not even being screened or tested. And when they're tested, they've got ferritins of 5 or 8. Like 80 milligrams of iron stores. How must that poor baby grow and develop? And there's so much, it's a pet topic of mine, about the development of the baby if they don't get enough iron during pregnancy, that, you know, and there's absolutely no harm in getting a ferritin above 100. No harm whatsoever. It's completely fine. It's actually good.
And the top value, we're moving to a little bit of, I don't want to move out of this podcast without talking about too much iron. So
yes.
If we say the top value of the ferritin.
Okay, so let's just address one misunderstanding about ferritin. The ferritin floating around in your circulation is not dangerous. That's an important point. Many people think if the ferritin is high, I definitely am having organ damage. It's not true. The ferritins, little tins floating around in your circulation, are often empty. They carry no iron. They might carry a little bit of iron, but that's not the problem. The problem is when, and this is the distinction, when you've got infection or inflammation, the body reacts by pushing out those stores, those ferritin molecules, even if they're empty, into the circulation, and now it looks like you've got too much iron. Yes, it might indicate that, but in my experience, more often than not, it doesn't. For instance, people who got fatty liver disease or are obese often have higher ferritins, and it's not in itself dangerous, but it tells you there's something else that's causing problems, causing inflammation. You need to address that. You must lose weight. You've got to get rid of the fat in the liver or whatever it might be. It's when your transport system, that's now the transferrin, becomes overloaded with iron. Then you get what we would loosely call free iron. There's not really such a thing as free iron, but let's say iron that's not bound to the properly designed transport molecules. And these transporters are called transferrin, little two-seater canoes I like to think of. And if there are more iron coming in than there are seats on these molecules, iron will end up in the blood and will go and bind to something and damage it. And it can damage DNA, it can damage cell membranes, it can damage anything and cause a lot of harm. And the way we know that there might be damage is when the transferrin saturation is above. We usually say we screen for problems when it's above 45%, but the real problems usually start when it goes above 60%. And then you start seeing cellular damage, and it doesn't happen overnight. And these people with too much iron, the problem with them is they feel nothing or just tiredness for 10, 20, 30 years before they get the organ damage. And this is sort of a delayed health problem. You're born with a genetic defect that causes more iron absorption, and you can, by treating it in a very simple way, you can literally prevent all the complications later on. But if you miss it and you don't treat it, then late in your life, it can cause a lot of problems. So circle back. It's not just the ferritin. The ferritin is just sort of, okay, let's see what's going on. Is this ferritin high from inflammation, or is it high from too much iron? Or is it high from alcohol? or liver disease, or whatever. There's many causes. It may indicate, but it doesn't mean necessarily. I think most high ferritins I get referred to that are fatty liver.
And that's quite interesting. I think that's maybe a point for our colleagues out there. So you can trust a low ferritin, but you cannot trust a normal or a high ferritin unless you know what the inflammation status is.
Exactly.
So that's quite a good point. So that's quite something we see a lot. We
see it quite often. Raised ferritins, but then we have the CRP done with it, and we can take it from there. And we use it as a screening test. So we use the ferritin and the CRP as our screening test. It's a cost-effective way of doing it.
Exactly.
And then if it's abnormal, then we go further and do the saturation and everything else.
Sure.
So again, for our colleagues, if you get a ferritin that's high, you do a full iron study that will give you the serum iron, transferrin saturations, and the ferritin, and then you should be triggered by a transferrin saturation of more than 50, or did you say?
So if it's very low, you're going to think about iron deficiency or inflammation. If it's very high, the saturation, then you're thinking of iron overload, too much iron.
Okay, and if you say very low, under 21 is very low?
Well, under 20% is generally, as a rule of thumb, low, but could still be part of inflammation. And there you're going to have to look at the underlying problem that the person has, because there would be different cutoffs for cancer, for kidney failure, for heart failure, for inflammation.
Okay.
They all have different parameters. So it's not a simple answer. But generally speaking, a very general rule, if your ferritin is less than 100 and your SATs is less than 20, you can probably safely treat that patient for iron deficiency. You're not going to do any harm. And if they improve, well, then you've made the firm diagnosis.
Okay. That's
and to the other side again, we use 45 as our cutoff. So 45
for too much.
For too much.
Yes, you're right, and that is the correct cutoff for too much. The moment is above the transferrin saturation. It's not the ferritin, but the transferrin saturation, like you say, above 45, means you have to go and screen the patient for iron overload, and that would typically be the hemocromatosis gene screening.
But that we will refer to a hematologist, or is that something a primary care?
Well, it's so common that it would. I think it's a simple thing that GPs can educate themselves about. It's common, as I said. 1 in 10 Caucasians have this gene, or 2 copies of the gene. I think in South Africa, 1 in 6 will carry the gene. So it's a very common thing, and hematologists. There are too few of us, so I'm interested in it. So I see many of these patients, but liver specialists often see it, gastroenterologists see it, and many GPs see it.
And the 2 genes that you normally ask for that C...
so there's the most common one is the C282Y, and that's the one that's about, as I said, 10% of people from Canada, North America, or USA has 2 copies, which means you've got hemochromatosis. We call it hereditary hemochromatosis. It's inherited. You need to have a copy from mother and a copy from father to actually have a problem. If you just got 1 copy from one of the 2, you're a carrier. And that's the group that I spoke about where these great athletes come from. So then you must say, I've won the jackpot because I've got this 1 copy. But if you happen to have another gene, because there are a number of other genes that can also lead to iron overload. So if you have 1 copy plus another one, then the combination can also lead to iron overload. And the other one that's commonly tested for is H63D. It's much less common. It's about, I think, not from South African studies, but from other studies, probably about 7% of people that would carry that one. And on its own, it's not harmful. If it's just 1 copy, and even many people with both copies of both H63D don't have big problems. We check them, but it's a minority that will actually develop significant iron overload, but they can. So you need to look at everything. But the C282Y, if you've got 2 copies, there are a few people who will not get problems, probably because they are women who bleed a lot, or they must be something else, but most of them need to be followed up carefully. and they can treat themselves, or not treat themselves, but they can be treated with bloodletting. Donate blood. Just donate blood.
And I think that's a very important point. I think, first of all, it's a very cheap screening test, the ferritin, and you can add many years to your life if you pick it up.
Absolutely. Totally. You can really make a huge difference. If you do not pick it up, I mean, especially men are at much greater risk than women. Women are, with these genes, tend to present with problems 10 years later than men. So men would present in their 40s or early 50s. Women will present in their 50s or early 60s. But, you know, that could have been the 80s, 90s, or 100s if you picked it up early in life and just advised them to get the right amount of blood, or to do blood donation, or you know, let their blood at your practice.
Yeah, and that's what we always say. We would love to screen people around the 30s, because we see people are pretty much bulletproof till they're 30.
Yes,
and then things starts changing. 35, you start needing to do a few things. So, and if you can pick this up early, amazing results. If you do
exactly.
You know.
And I think your family, if you know of someone in your family with this gene, you need to get screened. You know, especially if it's a parent or a sibling or a child. That means that there's probably going to be quite a few people in that family who's carrying this gene.
Question, if you do have the gene, at what point in your life will the ferritin go up? Only later in life, or will you have a high ferritin from early on?
No, it will go up later. And that's why, this is where the iron test early in life might not give you the full answer. It can. I've seen teenagers, I've recently seen a teenager who's actually had high levels early on, at least for a transferrin saturation, yes, but not the ferritin yet. So you first see your transferrin saturation going up, and that can happen quite early. But your ferritin can take decades before that gets to significant, to really, let's say, not to really high levels. And we usually say when the ferritin goes above 1,000 in a patient who's had high transferrin saturation, those patients are usually in need of liver biopsies and further tests to go and really see if they've got damage. So you want to pick them up long before that.
That's amazing. Iron is such a big part of our lives, but it's, I mean, the high iron is not what interests me that much. Is that billion people around the world? I can't believe that 1 billion people walk around with an iron deficiency, and it's not an absolute health priority. It's
I want to shock you. It's now 2 to 4 billion.
Wow.
It's the 1 to 2 billion is actually anemic. They've already got anemia, but there's another 1 to 2 billion that are iron deficient and they're not yet anemic. That's the estimates we have from the...
So the take-home message for our listeners is, if you don't know your ferritin value, you need to know it.
And if you need to know it, so I know mine, and I screen my wife's every 6 months, and now I've started screening my children, and I supplement them, and I still can't get them high enough. It's amazing how much iron you must actually give a growing child. So I think if people don't think about it, they need to know.
And absolutely right. Hey? And there are these periods where children's iron needs are particularly high. The fetus during pregnancy, the fetal development, critical period, between 6 and 18 months, adolescence, and then, of course, menstruating girls and women, their iron needs are much higher. But whenever you are going through growth spurts, you're going to use up iron like anything. You need to, and there's nobody growing faster than a fetus. And especially the brain of that fetus. It's what I'm so passionate about. That brain is absolutely dependent on iron. And if you don't get it right during pregnancy, that baby might have consequences that last into adulthood, even if you give them iron after birth. And this is what I think, this is a message I'm trying to also really get out to doctors and to people. I like what you said. You need to know your ferritin level. And there's never a time as important to know it as when a woman is pregnant.
And if it's low, get to someone that is actually schooled in this and get you to at least 100. That has to be done.
Correct.
Okay, I'm schooled. It was an absolute masterclass to have you here. Any passing points that you want to say before we?
Yes, it's just amazing. All the symptoms of low iron is so diverse.
Yes,
and you and ER and we all sometimes see all these funny symptoms, and you brought it into the picture, the development of the brain and the academic achievement of the children in school and things like that. So iron is much more than just the anemia, and that, I mean, that's my take-home message today. It's not just about the anemia; it's about all the other processes that's running around in the body.
And maybe that's a good point to, we're probably nearing the end, but the symptoms of iron deficiency are very non-specific, unfortunately. But there are some that are, when you have them, you really need to think about iron deficiency. The commonest one is probably cravings. And, as medical students, we always learn about these cravings, like you crave ice, or you crave dust or soil or paper or paint or burnt cigarette stumps or matches, whatever. All these funky, funny things, but it's very common. We did a study with some medical students where we looked at patients with iron deficiency, and we found that 2/3, 2 out of 3 had some form of craving. But we also discovered, and this is not well known in the literature, is that many people don't have a craving for a non-food or a funny thing. They just have an excess craving for some kind of food. Common cravings we see, cravings for chocolate. One of the patients was eating a whole bag of tomatoes every day. The other one ate 2 whole loaves of bread every day. Xylophagia, we call that. So there are these cravings that can be for non-food stuffs and for food stuffs. The other nice one is beeturia. When you eat beet, there's a pigment, the thing that makes beet, give it that pink-purple color. It's called betenin. Mm. Now, when it gets into your blood, the iron will take the color out of it, and your urine will be clear. If you don't have enough iron, the color of your urine will turn pink or purple. Now, obviously, if you're going to eat a bag of beets a day, it doesn't matter how much iron you have, you will probably still have pink urine or purple urine. But if you're eating normal amounts of beet and your urine is purple, that might indicate, well, I would definitely say go and get your iron tested. If you don't have purple urine, on the other hand, it also doesn't mean you don't have iron deficiency. Not everybody gets it, but it's some of these things to think about. But maybe we should just quickly remind the listeners, if you have unexplained, headaches, dizziness, palpitations, tiredness, anxiety, brain fog, cravings, feeling very cold all the time, hair loss, nails that break easily,
chest pains.
Of course, there are hundreds of other causes for all of these things, certainly. But especially if you're a younger person and you've been to the doctor and they haven't been able to find another cause, the simplest thing you can do is just test your iron. Just test your iron. Treat it and see what goes away. You might be shocked. We've got some bright psychiatrists in town that have sent me patients with anxiety that doesn't respond to treatment. Iron deficiency was the cause. In one case, we diagnosed colon cancer in a 32-year-old. And that's an important point, right? We must always look for a cause of the iron deficiency. The most common one is heavy menstrual bleeding or pregnancy. But especially in postmenopausal women and in men, we must look hard for a cause. It's not enough to say, you've got iron deficiency, here's your treatment. Why? Yeah. The doctor needs to have something written on his paper there. This is the cause.
And the most common cause that you're actually referring to is we need to have a gastroscopy and a colonoscopy, go look for a gastric bleed.
Yeah, we won't do that in teenagers or people with heavy menstrual bleeding, but certainly in postmenopausal women and in men, that's the route that you need to consider.
Yeah, for our colleagues out there, I think that's a very important point.
Absolutely. Yeah. And not just the one or the other. It has to be both.
Yeah.
We actually wrote those guidelines and they've just been published. It's top and bottom scopes. It's not enough to do the one and say, oh, I found an ulcer. No, you still have to do the bottom, because many people have an ulcer on top and something else at the bottom. You need to do both.
Maybe I'm just going to, we probably have 5 more minutes. So just treatment-wise, we talked about the tablets. So we said there's tablets, there's little sachets now that you can take. There's intravenous. So how should people think about, or maybe colleagues and our listeners, how they should think about supplementing their iron?
Okay. The most important thing to remember is there is a way to get your iron right. And do not give up if the first treatment you get gives you too much side effects or is not working. There are so many different types of things that can work. And if you've got constipation or diarrhea or something from the old cheap iron tablets, there are many new ones that one can try. Don't give up and don't blame your doctor. It's the name of the game. You don't know which one is going to work for who. Just ask your doctor for something different. If the oral iron tablets don't work, you need an iron drip. And these drips are very safe these days if given by people who know how to give them in the right place with the correctly trained people. And generally speaking, you can actually sort out a person's iron with a drip in one sitting, maybe 2 sittings for some who's really very anemic or so. But for most, you're going to be sorted out with 1 sitting instead of maybe 3 or 6 or 12 months of tablets. And if you add all those costs together, maybe the sums may make sense to go for the drip if you're struggling in the beginning. So speak to your doctor, tell them whether you are tolerating the iron or not, and nobody gets sorted out in 1 month. That's very unusual. You're going to need iron tablets for probably 3 months, and you need to check at the end of those 3 months whether you've sorted it out. And when you go for the test, don't take your iron tablets that morning of the test. First go for the test and then you take your tablets. Otherwise, you mess up the test. If you've been for an infusion, don't test for 6 weeks, because the infusion is going to affect those tests for 6 weeks. So that would be some of my take-homes on treatment.
I've got a personal story about that one. When Chantal, my wife, she had an infusion when she was that low, and she had the infusion, but I didn't understand all of this then yet. I just knew she needed the infusion, and she said, "Oh, it didn't help." And weeks went past, and she said it didn't help. And 4 weeks and 1 day, she woke up and she said, "Wow, I'm back." And it was like a light switch. So it's right what you're saying. Like, it takes weeks to hit the system, because it obviously gets grabbed by the marrow first to make the red blood cells, and then it actually goes to the tissue.
If you start off anemic, the body's first going to sort out your red blood cells, but you might still feel anxious and depressed and tired because all the other cells are waiting for their turn. You know, they're standing at the back of the line. The red cells are always first. They get the priority. They're in the fast lane, you know, that priority lane at the airport. They go in there, but the others have to wait.
Right. I think that's our hour. We could probably go on for another hour, but Vernon, this was amazing. I mean, I hope the people that listen to this will get a lot out of it. You've taught me so much about iron, and I believe it's next to oxygen. It's probably the one thing that you need next is your iron. And please get in touch with us if you need any more information. You've got a YouTube channel that we'll link onto the show notes. If people want to look, because I mean, you educate our colleagues to go and look at how iron metabolism and how to think about iron. Please get involved. There's a big drive now with patient blood management that you big part of. So if you're a surgeon or orthopedic surgeon or anybody that deals with blood transfusions, please get in touch with Vernon and get onto the patient blood management. and guys like us, I mean, we got schooled in iron, and I think we need to get it out to our colleagues. So.
Yeah, thanks a lot for your time being here, and the massive effort that you put in outside and educated all our colleagues about iron.
No, really, Shaun, thank you so much, and it's fantastic what you're doing. I love it. It was so nice to be here, and really enjoyed it. And I just want to say to the listeners, having listened to what Rudy and Shaun does, there's so much life beyond just not being sick, you know. I always tell my patients, doctors are typically trained, you know, from the point where you become sick to the point where you die. We try to get you away from dying, and we try to get you back to neutral. But beyond neutral, there's a huge area to wellness, to being super well and feeling fantastic. And it's not just for Olympic athletes. You can really be that. And iron is one of the key factors there. There are many others. That healthy living, things that cost nothing or very little, maybe just some time, can give you. Don't be satisfied with the middle point. Go beyond that. You want to be well. You want to be strong. You want to be sharp. And I love what Shaun and Rudy is doing in their clinics, and how they're looking at all these other things beyond the 0 point. But I think we should all take responsibility for our own health and move beyond the 0.
Thanks so much.
Thanks a lot. Disclaimer. This podcast is not intended as a substitute for the advice of your healthcare provider. No doctor-patient relationship has been formed through this podcast. The content here is for information purposes only.